It is an honor to stand before you today on behalf of the National Health Insurance Authority, the NHIA. I would like to begin by sincerely thanking the Ministry of Information for organizing this press conference and for providing a platform that brings together key stakeholders to engage the public on national development matters. Today's gathering is not only timely, but critical in raising awareness about the work we do and the progress we are making toward building a stronger, more equitable healthcare system in the Gambia. The NHIA was established by an Act of Parliament, the NHI Act of 2021, with a clear and focused mandate to implement and manage the National Health Insurance Scheme, the NHIS. This bold initiative by the government of the Gambia is a pivotal step in our nation's commitment to achieving universal health coverage, ensuring that every Gambian, regardless of status or location, can access essential health services without financial hardship. Since the rollout of the NHIS, we have seen remarkable progress. To date, over 29,000 have been enrolled and have actively benefited from maternal and child health services delivered through 69 contracted health facilities across all the 7 regions of the country. This progress would not be possible without the generous support of our primary donors, the World Bank and the government of the Gambia, whose contributions have been instrumental to the success of the scheme. We are equally grateful to our partners, particularly the Ministry of Health and the Ministry of Finance, for their continued collaboration, technical support, and guidance throughout this process. The NHIS represents more than just access to care. It represents peace of mind for families, a safeguard for mothers and children, and a system built on solidarity and inclusion. As we continue to expand our reach and strengthen our operations, we remain committed to transparency, accountability, and the core mission of making healthcare affordable and accessible for all. Once again, I thank the Ministry of Information for convening this important event, and to all our stakeholders, partners, and the media, thank you for walking this journey with us. Together, we're building a healthier Gambia. Thank you.
Thank you, Doctor, for that precise introduction of the NHIS system. And like I keep saying, it's a very important institution. I was teasing them the other day. I say, if well-management structure, you are going to be richer than the Social Security and Housing Finance Corporation.
Absolutely.
You are as important as that institution.
I have warned the MD of Social Security that it's just a matter of time before we overtake him.
Exactly.
So I'm glad you are thinking like
I'm aware. It's a very strategic institution. And then I'm glad that government is keeping an eye and is giving priority personally from the. Now the floor is open. If there are any additional questions or technical information, data, you already gave info. It's about solidarity and inclusion. That's some of the bedrock of our society. And then if there are some informations concerning the rollout, the due process, how to get the card, how to get covered, and then he has his team also to support. So the floor is open for questions, clarification.
So before questions, may I introduce the team? Have they been introduced?
Just formally acknowledge, but you may.
Okay, all right. So I'm here with my team, and this is the reason they're here, because the success of any leader is a reflection of the team performance. So today, I am strengthened and accompanied by Dr. Hassan Jai, who is the Director of Services. Hassan, you may rise. I have Mr. Aliu Sow, the Head of Membership and Enrollment. And go ahead, Aliu. Yeah. And he's right next to Our Lady for the Media, Communications and PR, Fatim Ka. Floor is open. Any questions? There is no. I can't remember exactly what I said in March, but with respect to hesitancy, it's probably awareness and knowledge. So we probably took care of it by increasing people's awareness. We did media campaigns. We went on radio, TV, social media. We are also in the print media. You see us on The Point and on the Standard. So if there is any other point, maybe I'll leave it to Aliu. But the situation has improved. People are very eager. In fact, we have more demand than we can satisfy. There are a lot of people who want to have the card. Registration is ongoing. It's just that our services are limited, of course, based on our financial strength. We want to take it phase by phase. Right now, we're doing maternal and newborn health. In January, we'll add some other interventions that may even include formal and informal workers. Yeah. So the situation has really improved, and that's just because of knowledge and awareness. It's our role to make sure we educate, we inform, and advise people on the merits and benefits of this. The idea of insurance anywhere, it's about payment. You talk about insurance, it's money up front, not so. But this health insurance says, no, you're not going to pay anything. Well, at least for the areas we're intervening now. We say mother and child, go register, be enrolled, get treatment, and we'll pay. That's a social protection. That is new. I go to the hospital, I pay from my pocket. And I'm in charge of the insurance. My staff go through the same thing. So the question is, when are we going to cover ourselves? Of course, the journey begins with one step. First, you look at the socially vulnerable. We are able-bodied, we work, we earn, so we pay for health. But the government and the Ministry of Health and the NHIA is devising a scheme where we will contribute and also benefit from the scheme. So it all starts with education, knowledge, and awareness. I hope I've done justice to your question. If not, Aliu can add more.
And feel free to ask in our native languages, the Gambian language.
All right, thank you. My name is Aliu Sow, Membership Manager for the National Health Insurance Authority.
Aliu, you may need to
come.
Yeah, come stand here.
Again, feel free to ask it in our native languages. Can also elaborate in our local languages.
All right, thank you. So in terms of enrollment, when we started, really we had some challenges. One of the challenges is that the enrollment, we do it digitally. And the idea of doing it digitally is to ensure accountability and transparency. So you may recall in 2021, there was a mass campaign and most Gambians went out and got the card. However, we still have over 1 million people who did not have the card. And the NHIA, through the World Bank support, partnered with the Birth and Death Registry to do the printing of the health cards. And during that period, a lot of Gambians actually had it, but nonetheless, we still have a lot more that did not have it. And you may also want to know that the National Health Insurance Act provides that every resident of the Gambia is eligible to participate in the health insurance scheme. So what that means is that even non-Gambians, women who are residing in the Gambia, who are legally residing in the Gambia for that matter, with a valid residential permit or a non-Gambian ID, are eligible to enroll into the scheme. However, our system had some challenges in accepting non-Gambians and even some Gambians because the health insurance card is being linked to the birth certificate. As per our act, once you are a resident of the Gambia and you are a Gambian, you are eligible. But for the birth certificate, there are other requirements that are attached to the birth certificate. And that is causing some challenges for some of the women coming to the health facilities. Again, we are implementing a project to ensure that that challenge is also eliminated. Through the Ministry of Communication and JICTA, we working on the disintegrating the two systems. So now what the government of the Gambia is doing is to build a system that is going to generate a national NIN number for every resident of the Gambia, or for every newborn that is born. So from birth till death, each Gambian is expected to have one NIN number. And that NIN number will eventually be on our ID cards, on our driving license, on our national health insurance card, and also even for non-residents, for non-Gambians who are residents in the Gambia, will also have a unique ID when they enter the Gambia. This has been done through the ministry and JICTA. So that project is in progress, and most of the technical work has been completed, and hopefully there are just some policy issues that need to be fixed, and once that is done, the government will come out happily to announce the progress in terms of that. And when that happens, again, the membership card will be easily accessible. Each person will be able to get the. Currently, you can only have the health insurance card when you go to the health facilities. And sometimes you may not want to go to the health facility because you are not sick. So you only go there when you are sick. So our plan is to roll out locations where individuals can easily get this card even without going to the health facilities. And we are also making sure we digitalize our system. Eventually, when we roll out to making payments and so on, people will be able to do digital payments, mobile payments, and all the enrollments will be automated. Again, just to ensure that there is transparency and accountability in whatever we do. So our CEO said we'll be bigger than social security. So we are preparing for that, to make sure that when we are bigger than social security, we will also be more accountable, more transparent. Thank you.
Thank you. Aliu, stand aside, don't go far. And it's logical because social security and health insurance are all part of social protection schemes. In most countries, you actually have social security and health together. In the Gambia, we have social security and housing finance. That's a unique setup. You can't find it in many places. Yeah, so, all right. Another question?
Thank you very much. My name is Yusuf Taylor, journalist for Askan TV. So my question is basically, you did mention that it's your you are limited by your financial capacity, yeah? Something along those lines, pretty much. So, and I observed, just preparing for this press conference, you increased from 13 facilities to 69.
That's correct.
Which is more than, it's quite a big job, isn't it?
Yes.
In one year.
That's what we call exponential growth.
Exactly. But when I look at the budget, I realized that in 2023, this is what is in the budget, your subsidy, National Health Insurance subsidy, you have 27 million, which was actually spent. And then in 2024, zero was approved. That's what I'm seeing here. Perhaps you can clarify. I know this year you have 50 million to work with, right? How much did you spend in 2024 to get these huge numbers? 29,000 people benefited, you said.
Okay. I think the first point of departure is a distinction between the authority and the scheme. So that zero figure you are looking at was the scheme. 2021, 2022, 23, we all had budgets for the authority, operating expenses. So in terms of providing a budget for 2025, 2024, 2025, that's when it was approved. So at the starting point, there was a confusion. Yeah? The original idea was that when you give money to the authority, you are giving money to the scheme. But everybody knows that, I mean, the scheme is huge. In fact, 50 million is not even enough. So the understanding was to reinforce the difference between the authority, which is us, the body of people, who incur operating costs, rent, salaries, building, cars, fuel. That's what the first budget allocation was for. And then some people were pushing from that allocation, we should be able to pay claims to hospitals. We said, no, hang on. If you do a pilot just with Bundung, I mean, you're going to be spending millions. So there has to be a separation. So luckily, during the budget bilaterals, we succeeded through the support of the PAMSEC Ministry of Health in creating a new line item called the National Health Insurance Scheme. Yeah. Now that separates us. See, the authority, here are your salaries, your operating costs, but do not touch money that is meant to pay claims. Now the 50 million came and said, if you take care of people at the contracted health facilities, the facilities will now send their claims and you'll pay them from this 50. Don't touch it for salary, don't touch it for travel, don't touch it for other things. And now the accountability is easier. Yes. So that is why you saw those gaps. What we were getting prior to 2024 was money for the authority. Now what we are getting is both for authority and for the scheme. Now the 50 is solely for the scheme. For the authority, there are other allocations which may interest you. All right? We didn't bring the head of finance, but if Hassan wants to add one or two to beef the data, yeah. We get monthly briefings, so the numbers are here.
Okay, thank you very much to the Honorable Minister and all of you for gracing this important occasion, also the Deputy Government Spokesperson. I also wanted to add some little update in terms of the evolution of the scheme. So the CEO mentioned that we started with a pilot in Bondo. But I also want to make a distinction between the authority, the scheme, and the National Health Insurance Fund. So the Act, the 2021 National Health Insurance Act, established the authority to oversee and manage the scheme, which is the National Health Insurance Scheme, and the National Health Insurance Fund. So to define the scheme are the services and interventions that members of the NHIS would be entitled to when they visit contracted public health facilities. So these are, if you get sick, you go for a malaria treatment, the investigations, and other things. This is what the scheme is about. The National Health Insurance Fund is a single fund that is domiciled at the central bank. Now this is where all the monies are, well, supposedly should be housed to pay for the members of the scheme in terms of their healthcare expenditure. So the authority more or less manages the scheme and also oversees the fund. So to give an additional update about the evolution of the National Health Insurance Scheme. So in July 2023, we started with a pilot in Bundung Maternal and Child Hospital. Bundung Maternal and Child Hospital is aspiring to be a specialist maternal and child hospital. They've made significant progress. They're not yet fully there, in terms of being accredited. And it was deliberate because the NHIS at the time had limited funding. So you need to be strategic in how you implement it. Due to the limited budget space, you also have to implement based on what is available. So we chose the most vulnerable population, that is women and children. But we even cascaded down to say women that are admitted for delivery and newborn and a very limited postpartum care. So again, it was deliberate. You spend within your means. At the time, the funds was only able to cover this. And also the CEO mentioned that the World Bank was also very supportive in addition to government to provide additional funding to pay for the scheme, the services that are covered. So perhaps that funding, the non-balance of the equation could be attributed to that because the World Bank was also injecting funds to cover for members of the scheme. So we started with a pilot in Bundung, and based on the experience, of course, with the challenges and opportunities, we decided shortly, 1 year later, to expand to 12 public health facilities. During this expansion, we ensured that all the hospitals are included, except Sheikh Zayed Eye Care Center. By virtue of being an eye specialist services, they cannot be included. We also included all the district hospitals, some major and minor health centers. We were also very strategic in this approach because these 12 plus Bundung, 13 facilities constitute about 50% of total deliveries in the country. So we thought that if we have 50% as a start, we should be able to cover at least the most vulnerable population. So moving forward, again, 1 year later, based on the experience, the opportunities, and the challenges, we were able to now enroll to the remaining public health facilities, totaling about 69 public health facilities. Someone might be interested to say, how about the private? Again, it's about strategic implementation. Because in health insurance implementations, the tariff that you set for public subvented or subsidized public health facilities would be different from the private. We know most of the private, even those that are supposedly calling themselves not-for-profit, are still profit-driven because they need to get the margin to cover for their operating expenses and also continue to provide the service. So the tariff for the private will be slightly different from the tariff for the public sector. So for now, our focus is public health facilities. Again, health insurance implementation is a learning curve, right? You don't just start and just cover everyone. And this is also a huge public policy that requires substantial investment. In a country where, of course, the economy is improving, the metrics are showing good signs, but despite that, there's still significant numbers that are unemployed, significant numbers that are considered poor, who are unable to contribute. And for social health protection schemes like health insurance, you need to be both contributory and non-contributory. Those that have the means should be able to contribute to cover those that do not have the means. So it's like a social solidarity. Dr. Caesars, and I, live in Scandinavia for a few years, and I studied there too. Those countries are considered progressive when it comes to social welfare system. But even there, they are unable to provide the entire health needs of their population. So this is why we have to be very strategic. We cannot just go full-blown, 100%. We have to be very strategic, and of course take note of the fiscal environment as well. Thank you.
Will you answer my question?
Okay.
Which was?
What I know is that the budget tells me that you spent 27 million in 2023. What I don't know, and we're in June 2020, July 2025, what I don't know is how much did you spend on the scheme in 2024 last year. That's my question.
So I was able to get something from the accounts this morning. Just give me a sec. I can give you a breakdown. So in terms of our expenditure, it comes in two folds. We are paying for claims for members that we have provided the services, and our contracted facilities submit those claims. And there is also the performance-based financing, which is exclusively funded by the World Bank. So in terms of the claims, in Q1 of 2024, we paid about 529,000. So it's gradual. Q2 2024, it increased to 4 million, right? Q3 of 2024, it increased to 6 million, about 6.2 million. Q4 of 2024, about 10 million. Now in Q1 of 2025, it's still at 10 million, 660. So based on the, yes, and this excludes the second quarter. In terms of the performance-based financing payment that I talked about, this is actually geared towards ensuring that you drive quality, right? In Q2, we paid, Q2 of 2024, we paid about 1.4 million. And we are not only paying health facilities, we are also paying the regional health directorates. We pay them about 1.6. So it's a little bit mixed because there's a, cash flow from the World Bank and also from domestic government. But we would be happy to provide a summary of these statistics.
And I guess the point is, we have or are going to spend every bit of that 50 million and more. Yes, and we are going to need more help from the World Bank. From the look of things, the figures that he's given you, you can see that we are already close to having paid over $20–30 million. So by the end of Q2, the 50 million is gone. So now the question is, how do we survive? Just like everybody, we go back and say, give us some more. That's all we do. Even His Excellency, when he sees me, he smiles. The first thing he says, "Why do you need more money?" And then I say, yes, we do. But we'll tell you exactly how much, because we arrive at it scientifically. And that's how insurances operate. But the good thing is, the data is there. They see that it's not coming from us. It's actually coming from the claimants. It's the hospitals that send their claims that are verified digitally. There is no fraud. Everything is verified. And so what you pay is what is out there. And when auditors come, they can follow the trail. Yes. So to answer your question, every bit of that budget money will be spent. Thank you. Can we? Yes. Another? Or you do?
If nobody has, allow my.
Okay.
Okay.
I can allow my colleagues. He needs a mic. Is it
There's no mic?
that mic is just for mic.
Go on.
Alaikum salam. kuy jël boobu Fatim wala Aliou kay wàllu mbindu mi moom Aliou moo ko moom.
ok jërëjëf laajte boobu am na solo foos ñu njëkkee ci kan moo mun a bokk si health insurance scheme bii nii health insurance scheme bi nguuri Gambia ñoo ko taxawal si atum 2021 lii mu ngi mun a xewee through act of parliament bi nga xamante ne dafa jaar si National Assembly bi ñu approve ko président bi sign ko loolu moo sampa National Health Insurance Scheme bi ak boobu ba tey moo wax ne képp ki nga xamante ne yaa ngi toog si biir réew mi war ngaa mun a bokka ci biir insurance bii nii mooy ne ndax Gambian nga ndax nekkuloo Gambian as long as yaa ngi toog si réew mi fii nii war ngaa mun a bokka ci health insurance scheme bi waaye boo nekkutee Gambian for example danga war a am kayit yu leer yu wane ne yaa ngi fi toog legally mooy ne danga war a am residential permit wala danga war a am non Gambian ID di fay sa lempo yi ak li nga war a fay ni nga ko war a fayee su boobaa yow it war ngaa mun a bokka ci kéeg bi so loolu mooy li nga xamante ne mooy bokkee bi mbindu bi si atum 2021 again amoon na campagne bu rëy bu xewoon si biir réew mi ñu bari ñu génnoon nañ ñu am kayit bi waaye ba tey am na ñi nga xamante ne amaaguñ ko lu tollu si 1 million ak lu teg jot nañ koo am ba pare waaye am nañ beneen million bi nga xamante ne tamit boobu tam amaangul waaye mbindu bi comme nu ma ko waxee pour nga mun a bokka danga war a nekk ki nga xamante ne danga toog ci biir réew mi nga am kayiti réew mi nga ID card la birth certificate la any kayit buy wone ne yow doomi réew nga wala comme su dee noonu Gambian nga wone kayit yu wone ne yaa ngi fi toog ñu ngi fi war a toogee nga war a mun a bindu bi war nga ko mun a def si bépp lopitaan bi nga xamante ne lopitaani nguur la ci biir réew mi ñu ngi faa bindu wattu bii nii gannaaw loolu tamit si biir bindu bi dinañ ci am jafe-jafe surtout si wàllum birth certificate bi presque ñun suñ ak bi dafa mun naa ne dafa yomba moom def ne yow boo nekkee doomi réew rek wala toog nga fi rek war ngaa mun a bindu waaye bu ñoo def campagne bi nguur bi dafa gisoon ne pour ñu mun a gën a am nit ñu bëri ba pare pour mun a dépense bi mun koo émale nañ boole insurance bi ak birth certificate bi ñu def ko benn so moo taxul ñëpp jéenandoor nga gis ne suñ la joxee birth certificate dangay amaale health insurance card so loolu stratégie la woon bi nga xamante ne pour wàññi dépense bi la waaye loolu terewut buñ demee ba gis jafe-jafe yooyu ñu delluwaat toog waxtaan gis ne dina am solo pour ñu séparer ñaar yi right so through the Ministry of Communication ak JICTA ak the Ministry of Health ñu lead that project bi nga xamante ne nguuri Gambia ñoo ko nekka di fond te fu mu nekka ni start na liggéey bu bari def nañ ci liggéey boobu noonu lu mooy tënkam mooy naka la ñoo boolee health insurance card bi national ID card bi driver's license ak birth certificate bi xelaat bi yëpp pour lan la pour gis ne bépp doomi Gambia wala képp ki nga xamante ne yaa ngi si biir réew mi yaa ngi am a unique identifier maanaam yaa ngi am benn nomba bi nga xamante ne boobu moo lay wone te nomba boobu du nuroo ak kenn for exemple tey soo ne Aliou am na Aliou yu bari waaye suma niin nomba bi nga xamante ne boobu laa am man kenn maa ko am si réew mi so loolu lañ bugg a def nga gis ne képp ki nga xamante ne ci réew mi wala yaa ngi fi toog dangay am niin nomba bi nga xamante dafa unique loolu stratégie la bi nga xamante ne stratégie government bi loolu dana yombal nga gis ne suñ demee ba nga xamante ne projet boobu complete na dangaa gis ne ñun suñ système bi ak yeneen système yi danañ attaque ci système yi EID boobu noonu bi nga xamante ne boobu mooy generate those IDs dangaa gis ne den ku nekka dana mun a am a health insurance card te du jafe dana mun a am si lopitaan yi danga koy mun a am si yeneen place yi nga xamante ne nekkul si biir lopitaan yi so loolu mooy xelaat bi nga xamante ne ñu ngi ci boo delloo ci gannaaw tam nga ñëw si liggéey bi nga xamante ne jot nañ cee def ak njëriñ yi nga xamante ne jot nañ cee am mooy programme bi Dr Hassan waxtaanoon na ci tuuti ne dañ ko commencé atum 2023 si pilot bi nga xamante ne boobu bundul lañ ko defoon pilot boobu noonu ñu ci mënoon a bokk si health insurance bi mooy jigéen yi nga xamante ne dañ toolu si waxtu am doom ak seen doom yi nga xamante ne yooyu lañ am gannaaw buñ tooloo si waxtu bi so pilot boobu noonu ñu jógee fa dem bu ñu def ko 6 months 2024 ñu yokkat ci yeneen fukki lopitaan ak ñetta mooy lopitaan yu mag yu nekk si réew yi yëpp lopitaan yooyu soo seetee ñu fay am doom daanaka cover nañ 50% of jigéen yuy am doom si biir réew mi so that was also strategic then ñu roll out this year to another 57 yóbbu ko to 69 health facilities so fu mu toll nii ñu ngi si 69 health facilities yi nga xamante ne bépp jigéen bi nga xamante ne toll nga ci am doom dangay dem si lopitaan yooyu noonu pour mun a bindu pour mun a bokk si scheme bi so loolu mooy programme bi nga xamante ne foofu lañ tolloongu suñu bébét nag mooy gën koo yaatal boole ci ñëpp parce que loolu la suñu ak bi wax pour ñëpp mun cee bokk ak mun a àggal lu ñoo wax universal health coverage jërëjëf. waaw Fatim yes am nañ number bi ku responsible member bi mu ngi ñëw
head of
PR mu wax leen ci tuuti ak yeneen li nga xamante ñu ngi koo def Fatim.
Good morning maa ngi nuyu ñëpp ku nekk si turam ak santaam NHIA nag wala NHIS the scheme am nañ number boo xam ne 1022 la number boobu noonu képp ko xamante ne call nga ko
repeat
1022 képp koo xam ne call nga si number boobu noonu bépp laajte boo xam ne am nga ko ñun dinañ la tontu wax la naka nga mën a bokkee si scheme bi jërëjëf.
Okay. Honorable Minister himself. In English or Wolof? Wolof, okay. Go ahead.
man mi nga xam ne ministre la. man mun naa bind man njëriñoo si National Health Insurance Scheme.
Aliou yow bul di sori fii.
waaw
everything about.
waaw thank you waaw bindu bi ñëpp la comme lu ma wax ci gannaaw ñëpp war na ñëw mun a bindu képp ki nga xam ne yaa ngi toog ci biir réew mi ndax Gambian nga ndax noon Gambian nga make sure nga get the right document pour ñu mun laa binda pour noon Gambian yi foog nga am noon Gambian ID ak permanent naka residential permit so for Gambians birth certificate bi is essential so boobu waxtaani beneen waxtaani beneen soo demee bindu pour ñaar la ok let me clarify ñaar moo am bindu bi ak bokka su ma ko mun a waxee noonu bindu bi mooy ne dem nga am carte bi soo amee carte bi ñëpp mun nañu am carte bi parce que lu tax ñu bugg a ñëpp ñu am carte bi ñu ngi progress gis nga ne start nañ with one health facility dem nañ si 13 ba 69 ñu ngi start with one services mooy women coming for delivery ak their newborn So our plan is to pour ñu yokka service. So suñu yokkee services, for example ñu yokka ñu decide ne ok am nañ fond or am nañ the capacity pour ñu yokka let's say the public sector ñi nga xamante ne ñu ngi liggéey si nguur mi. So yow su fekkee ne amaanguloo wala bindoonguloo dangay am tardement moo tax ñuy encourage ñëpp ñu am carte bi léegi soo amee carte bi there is another step mooy ne mooy enrollment bi mooy tax yow léegi nga war a mun a njëriñoo service bi. ñu bari am nañ carte bi waaye mënuñoo njëriñ service bi presque enroll laanguñ leen ñu nekk di enroll right now mooy service yi nga xamante ne yooyu ñoo available te yooyu lañ nekk di enroll mooy benn service sooy am doom right now mënuloo njëriñoo mënuñoo bokk for now waaye loolu miinul ne
waaye mu ngee ñëw Aliou ngee ñëw
waaye loolu miinul ne ñun suñ service dafa limite si ñii rek dañoo commencé liir bu ndaw la foog ñu doxaangum naka raam toog ba dox fu mu nekk nii commencé nañ ak the most vulnerable population si at yu passé gannaaw tuuti rek ñun yëpp ñu ngi fàttaliku Women's Life Matters Gambian Women Lives Matters ndadu loolu lan moo ko waraloon presque jigéen ñu doon am doom si lopitaan bi amoon nañu bari ñu see gaañu léegi waxuma loolu amut waaye loolu léegi wàññeeku na trop si lopitaan yi te amul ci loolu jigéen yuy am doom comme out of pocket xaalis bu ñu doon spend time boobu soo demee si lopitaan bi pour am doom lu ñu doon spend léegi dafa wàññeeku presque lu tax léegi NHI ñu ngi leen a jox xaalis ndax CMS sobnaay la leen garab wala soblaay ñu lopitaan yi ñoom danañ mun a léegi jël xaalis boobu jënda garab def ko si lopitaan yi nga gis ne jigéen boobu noonu su ñëwee moom léegi du feyaati dara.
Aliou waxalaat loolu.
right
NHIA
waaw
waaw mooy ne
waaw
soo nekkee jigéen
waaw
nga dem wasini lopitaan
waaw
doo fay dara
doo fay dara
garab nag soo ko usee garab
doo fay dara
waruloo fay
waaw exactly waruloo fay dara right waruloo fay dara soo demee soo nekkee jigéen presque dafa am ñaar lu fi nekka benn bi mooy government bi dafa am policy bi nga xamante ne dafa ne jigéen ñuy am doom duñu fay dara si lopitaan bi ndax du waaye dangaa gis ne ndax loolu actually loolu moo nekk di xew soo demee si lopitaan bi loi bi def na waaye dangay joxe loo am soo demee si lopitaan bi mu bugg na laa jox garab waaye su ko amutee du la ko jox even su dee police yi mu ngi fa ne bul fay waaye léegi NHIA loolu pax boobu la ñëw fata gis ne lopitaan yii nii yu ñu wax ne jigéen su ñëwee si yow bu mu fay dara danañ make sure ñu am fond bi nga xamante danañ make sure ñii ñu am xaalis nga gis ne jigéen bu ñu wax noonu du fay dara su ñëwee in reality du fay dara so loolu moo xam yes su soolee garab bu amul si lopitaan bi danañ ko ne mu jëndi ko waaye loolu tam dana affect lopitaan bi yaa ngi fàttale ko Hassan mu ngi doon wax si quality parce que ñoom Hassan ñun exactly
ñun bëgguñ situation boo xam ne
so Hassan baal ma may Hassan ñu leer la pour nga gën koo xam
honorable Aliou ko bu Jansoko si commencement bi ñu ngi tàmbalee jigéen yoo xamante ne ñu ngi waaj a am doom ak seen liir yi ak postpartum mooy suñu amee doom su diir yi fukki fan wala juróom-ñaari fan sa laajte bi am na solo ndik yow bokk nga si nguur bi si cabinet bi dinaa ngi jël ay jéego pour mun a gis ne lopitaan yi ñoo am garab yu doy diagnostic services ak imaging yi mooy comme scanning ak yooyu yëpp mu doy waaye fu ñu toll nii ñu ngi am ay manqué because garab yi doyut dëgg la ñu ngi def seen kem kattan pour mun a gis ne lopitaan yi am garab yu doy waaye ba léegi manqué am na so dina am situation boo xamante ne jigéen bi dem si hôpital bi dina am yenn garab dina am yenn test yoo xamante ne du ko fay waaye yeneen test yi mun naa am consumables bi moo jeex ñu ne ko na bii mënoo koo am foog nga dem private wala ñu ne la garab bii ak bii nga war a am di nga am ñetta waaye ñeenteel bi doo ko mën a am so boobu foog nga dépasse ko si private pharmacy bi waaye soo gisee sax ñu taxawal health insurance bi social health protection la so man ma ko dee misaalee mooy ususu wérgu yaram right so damee ba taxaw ñëpp contribute ñoo xamante ne comme ñun ñoo xamante ne ñu ngi liggéey weer bu nekk ñu jël tuuti suñ salaire bi percentage ñoo xamante ne tamit ñu ngi si informal sector bi mooy ñoo xamante ne ñu ngi daan seen doole bi outside the formal economy ñoom it ñu dogal tuuti xaalis boobu la ñoo dajale suñ ko dajalee li ñoo def mooy dañoo def lu tubaab yi dee ooye cross subsidization ñu am waaw ñu jàppale ñoo xamante ne dañ ñëw doole si kàttan si dépasse ñoo xamante ne wér nañ ñu jàppale ñoo xamante ne ñoo feebar productive base of society mooy ñoo xamante ne ñu ngi yëngu mën nañoo daan seen doole pour am xaalis ñu jàppale mag yi ñoo xamante ne mënuñoo def dara because of kattan ak yu ndaw yi liir yi ak xale yu ndaw yi ñoo xamante ne mënuñoo liggéey so concept boobu mooy social solidarity sometimes dañ ko dee mën a extend sax ñu ne financial solidarity pour mën a gis ne ñu aar ñëpp so that soo amee benn feebar wala yeneen jafe-jafe si bunti wér gu yaram bi soo demee doo fay. The good news is, maybe I'll shift to English, is currently the NHIA has worked with the Ministry of Health to develop 2 cabinet papers. So, in fact, yesterday we were updating based on the minister's input. One of the cabinet papers is to do the amendment of the NHI Act. Because the current act, we're facing some challenges to realize funds based on some of the revenue streams that were identified. That's one. So yeah, I just wanted to give that because it's also an advocacy. He will be in cabinet and hopefully he can also advocate for this. So because of those challenges, we're proposing some new revenue sources together with the Ministry of Finance for Muna Depa's health insurance. That will also address some of these stock out of essential medicines and consumables. Benen cabinet paper be more benefits package. Currently, we are implementing maternal and newborn services. In fact, a subset of that. Now we are proposing to cabinet to include at least additional 7 interventions, right, including non-communicable disease, which is a problem in this country. Because in the Gambia, we are currently faced with a double burden of disease. We have high-rising non-communicable disease like hypertension, diabetes, cancers, some cardiovascular disorders. It's on the increase. 3 weeks ago, I was in a meeting where we were looking at the numbers. It's scary because now we are seeing that increase within the youthful population, which is a disaster. And there's also increasing number among women that are pregnant. So which means that genetically you can pass that to the offspring. So you can have a population with high incidence of NCDs. The other one is communicable. We are still struggling with infectious disease. So the plan is to increase those interventions so that we can provide more services to the population and people can benefit from it. So si kalaami wala si gaawtal rek mooy ñu ngi jël ay jéego with the Ministry of Health pour mën a gis ne benefits package bi mooy yoo xamante ne askan bi dañ ko yelloo suñ demee si lopitaan bi pour ñu yaatal ko. The other thing mooy pour amend the act bi right now because act bi ñu ngi am ay jafe-jafe pour mën a dépasse scheme bi. So ñaari policy yooyu noonu no, the Honorable Minister is a passionate advocate. Hopefully, when it gets to cabinet, we'll get the support. Thank you.
More questions? Nu ñoy waxee act ci Wolof charter NHIA act mooy lan ci Wolof loi français la but you get the message. Yeah, go ahead please. Thank you. It's a very important question. First of all, we have what quality assurance manager. Benefits and quality assurance manager who does periodic checks and goes to the hospitals or contracted facilities that we sign with. And if the score is low, those facilities do not get the full benefits that they're eligible for. Like we said, we are a purchaser of what the hospitals are selling. The NHIS is part of the infrastructure and ecosystem, but insofar as buying services. The hospitals own their space, but in our contracts, we put our expectations and how we want them to conduct, high quality services. But quality is always relative. That's why you notice we say access to affordable and quality service. When you start bringing high, what is high to you may not be high to someone else, not so. But there are general standards of quality that every health facility has to stick to. Otherwise, you do not get your full points. Our monies that go to the hospitals are driven by key performance indicators. So if those KPIs are not met, the facilities do not get the full potential of the funding. And like we were saying, the whole essential point of funding this is to avoid those stockouts, to avoid those deficiencies in services. When we put in money and they have it, they do not have to wait for their traditional streams of revenue. The NHIA funding is additional to what they are used to. Not so. They used to do all these services without us. Now that they have us, it should make a big difference. Not so. Hassan, if you want to add a thing or two.
Yeah. So I will start at the highest level, the Ministry of Health. They have a quality assurance unit that oversee quarterly quality of care assessment. So every quarter, teams of quality assessors, called them quality champions, will visit all the public health facilities to assess their quality of care. It's very comprehensive. They look at the human resource aspects, they look at the infrastructure, they look at the service delivery itself. At the end of the assessment, they give them a score. This is important because for us NHIA, it tells us the performance of each of these facilities, right? And this is also important when we are paying them their performance bonus. Remember I said there were two revenue streams for the facilities. One is the claim and the other one is the performance base. Based on their performance with the quality, that is, providing quality services, we're able to reimburse them for that. Another layer is NHI's member satisfaction. Every quarter we also do a satisfaction survey among members to elicit their perceived level of satisfaction. So this also goes into the computation of how much they got as part of their performance bonus. But overall, when we are processing the claims, we are not just sending the claims to say that I've provided service A, B, or C. We also have to verify that, right? We have regional claims verification officers who, after those claims are submitted, will go back and check. So usually they check this against national standards. The MOH has set standards, manuals, and procedures that should guide service delivery. So this is another layer. But of course, it's an important question. Continuously, the Ministry of Health is also trying to improve quality so that we don't just pay for quantity, but quality.
Thank you. Thank you. Yeah. Another? Yeah. Okay.
I think I'll just ask all my questions. A bit of them. You can bear with me.
How many more do we have? Apart from him? You got more questions? Okay, go ahead. You can ask one or two. I don't see any other people interested in asking.
Then I actually have to. So you have about 69 health facilities, and are any of them private? I know you
not yet. Yeah.
Perhaps it's also good for us to get a list of these facilities so that the public.
They are available and they will be made public.
Perfect.
Yeah.
So that's my
Fatim's responsible for it.
So my second question, it seems at the moment only women can benefit from the scheme. And you stated that 29,000 people have benefited so far. Is this from 2023, 2024? And then my issue is to know, since it's only women and children, how many women and children benefited amongst it? Is this only in Bundu?
It's true. Aliu can give you the granular data, yes. But the scheme took off really after the July pilot, 2023. So it's from 2023 to date. Exactly. Yes. Yeah. And when we say to date, we have not even taken the second quarter of 2025. So it's going to go up a little bit. But the granular data, we can give it to you. It's women and newborn. Not so. Yeah. Now, on the facility, the private facilities, I can tell you, the private facilities cannot wait for us to sign. Currently, I am sure they are encountering a lot of problems with the medical insurance guys now, in terms of late claims. See, when we come in, we give them the comfort that our patients can be taken care of in both, too much gesticulation. So in both the private and the public facilities. And because we are a national health insurance scheme, we will have stable resources and our payments may be more timely than theirs. So it is guided by contracts. We have to look at the contracts. And again, as Hassan mentioned, the tariffs are a bit higher, because they have more specialized services. So it is something we have to study. It's something we have to do properly. And that is why, like Aliu said, we want to do these things properly and correctly now. When you do the public health facilities throughout the country properly, when you move on to the private facilities, you will also do it in a much better way, and it will comfort them. They will have more assurances to take care of our patients.
Fantastic. I think that will also help with the drugs issue, because we know that usually the private ones will have the drugs. Maybe a bit expensive, but the ones which are missing, doctor's question. My last question. Thank you so much for answering so far, and I will follow your guys for the data. It's a follow-up from the budget question and your response. Since last year, they approved zero, right? For the scheme, right? I'm speaking specifically for the scheme. And you did highlight that World Bank came in, which obviously anybody will be happy for. Did the government spend any money on the scheme specifically last year? Because they're showing that zero was approved. So I know they've approved 50 million to be spent, right? Which is almost done. And hopefully the partners will come in again. But my question is, last year,
2024.
Did World Bank put the bill for the scheme
yes.
specifically?
Yes.
Government didn't give any money.
Well, first of all, government money is World Bank money. World Bank money is government money. Every penny World Bank pumps into the health insurance, they do it on behalf of the government. So while we want to do, for financial reporting purposes, some distinction, but rest assured, whatever World Bank is doing here, they're not doing it for our pleasure. They're doing it as support to the government. And guess you what? It has to have the approval of the Minister of Finance. So World Bank money is government money.
Yeah, but I think what do you think is that the GLF?
Yes.
But the GLF...
Yeah, we told him. GLF for 2024, there was nothing for the scheme. Yeah, but for 2025, we have the 50 million that we are going to use. Again, that emanated from that confusion from the beginning, where they thought that when you give money to the authority, you are giving money to the scheme. But with the creation of that separate line item, through the Accountant General, now there is a clear distinction that whatever monies are coming for the scheme cannot be used for the authority, and whatever money is used for operating expenses is not expected to pay claims reimbursement. Clear?
I have a final question.
Yeah, go ahead.
I have a final question. And you mentioned that you might go private. You might include the private clinic.
It's part of our plans at the right time.
Would
Yes.
that lead to abuse, where people will now prefer to go to the private clinic and not the public because of the facilities? The facilities incurring more cost to you. And secondly, also, if you are ready to engage private clinics, and we have identified that there's a problem, that if you go to the public clinic sometimes, the medicines are not there. You have to go to the pharmacy. And is there any plans to have a deal with the pharmacies so they can invoice you directly from specified pharmacies? Is that possible?
Okay, very quickly. I think Hassan will come in, but let me just say that we will not be requiring our members to go to private facilities for services that they can get from public facilities. So it will be guided by contracts, and mostly it has to be through referrals for services that we cannot have, and then they can go. And that's why we say at the right time, we look at our health benefits package, and the ones that cannot be done at public health facilities, then they can go. So we have to make sure we do not cannibalize our own services. So Hassan, you can add.
Yeah, so like the CEO said, that's a strategy for now. But in the long run, okay, I also forgot to mention that we also have a credentialing system. Also answer Sonyazi, that will also address your quality question. We don't just want to contract any service provider. So the credentialing is also a very high level quality standard that any facility that wants to be part of the scheme should attain in terms of having the right staff mix, having the right medical stock and all that. If you meet that threshold, then you will be eligible. Of course, there will be an assessment before you are. So for now, we are doing a blanket credentialing because, like you know, the public sector, the perceived quality care is still challenged, right? So, but with the funding that is coming their way, we're hoping that they can improve to such a standard that when we are ready for the credentialing, they will be ready to pass. We will have the same credentialing. Of course, the threshold will be different, like I said. Even for the tariff, it will be different from the public. For the private, the Act clearly states that they are also, should be part of the scheme. So what is good about public-private mix, like all other countries that implement social health insurance, is its cost performance. Where there is competition, there is continuous investment to improve quality, right? Currently, if you bring both, the public might suffer because of the passive quality of care. You know, quality of care is never structural and process. If you ask me what I know, is process-wise, public health facilities are doing very well. Structural-wise, private are doing some meaningful development. Because usually, structural quality is tangible, you can see it, whereas process quality is missing. So we will have this credentialing for both public and private. Hopefully, when we have this credentialing, we will set up and we will start. Of course, like you know, private providers, we should be able to contract them. So if, for instance, certain diagnostic like CT scanning, if it is not available, the member can go to a private, get that service, and then they can invoice us, and then we can reimburse them. So these are all progressive ideas that are on the table. Hopefully, if they work, we should be able to address most of those concerns.
Thank you. But not private pharmacies.
Yes, not
It's the central, the government pharmacy.
Mm-hmm.
All right. And to put it in perspective again, insurance is not a one-day project. It's a 50-year project. We're just in year 3. And financially, just in year 1. Because the scheme came to life this year. All right? So the other countries that have done it, and we always like to take the examples of Ghana, Rwanda, Tanzania. Tanzania has been at it for what, 20-something years, and it was just last January that they commenced their journey for universal health coverage. So they had a fragmented scheme where every region, every division did their own thing. Now they want to do it under an umbrella of one NHIF. They call that National Health Insurance Fund. It's the same. For us, the fund sits at the central bank, and then when you open the tap, it leaks into the authority and into the scheme. It's the same. Ghana, they've been doing it for what, over 20 years. What's the coverage? 50%. Rwanda, by contrast, similar period, 20-something years, 90% coverage. So again, where there's a will, there is a way. All we can do is set the right structures so that the people who come after us can carry it through. Our legacy wouldn't be staying here to make it happen. Our legacy will be setting a strong institution that can be run by anybody who takes after us. Thank you.